doctors. This is Maya, a math student, and today we're gonna talk about Kawasaki disease. So, what's Kawasaki? Kawasaki, it's an acute, self-limited, systemic vasculitis of unknown etiology. We do not know the true cause behind it yet. It predominantly affects medium-sized arteries, especially the coronary arteries, which will later on lead to cardiac problems, and it is the leading cause of acquired heart disease in children in developed countries. Now, moving to the etiology. As we said, it's a disease of an unknown cause. So, there have been some hypotheses that an infectious trigger, a viral agent, causes immune overreaction, and this could be true since the disease affects children between 2 to 5 years old, and the immunity at that age, it's still developing, so maybe. We have a genetic predisposition, higher incidence in Asian children, especially Japanese, and the name Kawasaki comes from Japan. Gene polymorphisms, example ITPKC, which is linked to immune dysregulation. Now, moving to the pathogenesis, there is a trigger, unknown trigger that enters the respiratory tract. It could be infectious, it could be environmental. Then there's immune activation, where a massive activation of T cells, especially the CD4 positive cells, monocytes, macrophages. Then there's overproduction of pro-inflammatory cytokines TNF-alpha, IL-1 and IL-6. Then there's vasculitis, where inflammatory cells infiltrate and damage the vessel wall, which will lead to vascular injury, endothelial damage, which will then lead to aneurysm formation. The healing phase, we have the myointimal proliferation, which will then cause stenosis. Stenosis will then provoke ischemia, and you know how the cycle goes. Ischemia, no oxygen to the myocardium. Low oxygen or no oxygen might lead to MI. We can see the troponin, the change on the ECG, and that stuff. Now, the diagnostic criteria, you should remember, let's make it fun. Remember a guy on a motorcycle, he crashes and he burns himself. Crash for diagnostic criteria, and burn for the fever. Burn. Fever, it's something that's mandatory to be present. Fever more than 5 days is mandatory, plus 4 or more of the crash criteria. What's the crash criteria? C for conjunctivitis, bilateral non-exudative, and it spares the limbus. R for rash, it is polymorphous, desquamating. A for adenopathy, cervical lymph nodes enlargement more than 1.5 centimeters, strawberry tongue or oral changes. H, hands, feet, rash, edema, peeling. And again, the mnemonic is crash and burn. The laboratory findings, you should know that there's no specific diagnostic test to do for a patient with Kawasaki. However, some supportive clues do exist, like elevated ESR, elevated CRP, elevated white blood cells, neutrophilia, and left shift. What does left shift mean? That we have immature white blood cells, increased platelets, increased liver function tests, mild anemia, sterile pyuria, and we use echocardio to assess coronary artery involvement. Now, moving to the types of Kawasaki. The classic, that meets the full criteria of fever and 4 or more of the crash. Now, the incomplete and the atypical, it is less than 4 criteria plus there is echocardiography abnormalities. Kawasaki disease shock syndrome, it is severe with a poor prognosis, severe form with hypotension and multi-organ involvement. Now, the complications. As we know, since it's a vasculitis, it affects the arteries, the vessels, and since the endothelium becomes weak, when there's damage for this, there is collagen exposure and attack by the immune system. Every time it needs to repair itself, it will do some fibrosis, which will make the wall very thin. Since the wall becomes thin, there is a risk for coronary artery aneurysms. We have dilation, then aneurysm, then stenosis, thrombosis. If the aneurysm is a giant one, more than 8 millimeters, there is a risk of rupture. Once the aneurysm ruptures, there's a risk of bleeding, ischemia, infarction, sudden death. There is a link of myocarditis, pericarditis, and valvulitis, especially mitral regurgitation. Please remember that. Macrophage activation syndrome, which is a hyperinflammatory state. It's a severe one. Systemic arterial aneurysm affecting the axillary artery, axillary artery and iliac artery. Now moving to the treatment, we have the acute phase where we should give IVIG 2 gram per kilogram within 10 days of fever onset, high dose aspirin 80 to 100 milligram per kilogram per day, then low dose 3 to 5 milligram per kilogram per day. But be careful with aspirin, as you might think we might have Reyes syndrome. I think I've mentioned it later on. Reyes syndrome, where we have what? CNS involvement and liver involvement. Now, moving to the refractory cases, if we've already given IVIG and the child is still not responding, we give a second dose of IVIG or corticosteroids, and emerging new drugs, the biologics. We have infliximab, anti-TNF alpha, anakinra, IL-1 blocker. Yes, and for follow-up is based on echocardio, and we have to give long-term aspirin anticoagulation for aneurysm. Now moving to the prognosis, it is of excellent prognosis with early IVIG treatment. Risk of coronary complication will decrease from 25% to less than 5% with the correct treatment, so make sure to make the right diagnosis on time. However, we should monitor, we should always have a cardiology follow-up, since we might still have aneurysms and cardiac problems, so make sure to follow up your patients. Counsel on long-term cardiovascular risk and healthy lifestyle. Now moving to vaccination precautions. Live vaccines like MMR and varicella should be delayed 11 months after the IVIG dose. Inactivated vaccines can be given on schedule. COVID, which is something new to note. It can be given after 3 months post-illness under cardiologist supervision, since there have been links between COVID and cardiac problems, cardiac diseases. Yes. And as I've mentioned before, be cautious with aspirin in children because there might be a risk for Reyes syndrome. Now to summarize, Kawasaki disease, it's a childhood vasculitis affecting coronary arteries and medium-sized arteries. Diagnosis is crash and burn. Major risk is coronary aneurysms, which might later on lead to myocardial infarction and death. Treatment: IVIG plus aspirin plus or minus corticosteroids and biologic, depending on the case and the availability, of course. In some countries, there are no biologics, or maybe patients don't have enough money to pay for biologics, so And we should always follow up our patients by doing echocardio. Vaccination timing should be established based on the last dose of IVIG. And that's it. Thank you.